Hello, everybody, and thank you for joining me in this short video presentation from ECG Exercises. I hope you will enjoy it and join me in my future video presentation here. If you are new to my channel, please do not forget to subscribe. Today's ECG belongs to a 23-year-old man, completely asymptomatic, who was referred for routine examination before elective cardiac surgery. This is the ECG, which shows complete dissociation of atrial and ventricular activity, congenital AV block. So every time, especially when we encounter complete AV block in patients younger than 50, we have to think about reversible etiologies of AV block, which all were excluded in our patient. In addition, reviewing his medical report showed complete AV block in earlier ECGs from childhood. So we finally made a diagnosis of congenital AV block. One interesting phenomenon in his ECG is ventriculophasic arrhythmia. As you see, the PP intervals are not regular in this ECG. So what is the mechanism of ventriculophasic arrhythmia? So we can explain it with two different mechanisms. First, positive chronotropic effect is defined as sinus rate acceleration brought by ventricular contraction and has two mechanisms. The stretch of the right atrium caused by ventricular contraction, which augments the sinoatrial node automaticity, and two, increase in blood supply to SA node initiated by ventricular contraction, which accelerates sinus rate and shortens the PP interval interposing a QRS complex. We can also explain this finding, ventriculophasic arrhythmia, with negative chronotropic effect, which is defined as sinus rate deceleration affected by ventricular contraction, and its mechanism involves a vagal reflex caused by the stimulation of the arterial baroreceptors system by the pulse wave front of the ventricular contraction. Ventricular contraction elevates arterial blood pressure, which subsequently activates the arterial baroreceptors, and after that the vagal reflex slows the sinus rate and lengthens the PP interval without a QRS complex. So we can either explain it as a positive chronotropic effect of ventricular contraction or negative chronotropic effect of ventricular contraction, which finally results in ventriculophasic arrhythmia. This is a very important study which showed that patients with AV block younger than 50 with pacemaker has a worse prognosis compared to the other patients, especially in patients like our patient, which has persistent AV block. What is the reason? And here is the reason. For AV conduction, we need many proteins which in ion conducting channels, structural proteins, nuclear proteins, and metabolic proteins. And these proteins are vital in AV conduction. So any mutation in these protein structures and any mutation in the genes coding these proteins can cause AV block alone, but most commonly with cardiac or extracardiac manifestations. So if we have a patient like our patient, younger than 50 with AV block, so also we have to consider different kind of genetic mutations which can cause AV block with or without cardiac or extracardiac symptoms. Congenital AV block in 40% of the patients is accompanied with congenital heart disease, but in 60% of the patients, it's without congenital heart disease. And in almost all the cases, the reason is autoimmune congenital AV block, as you can see here. So the point is that as our patient, as an adult patient, which is asymptomatic, needs a pacemaker, in patients with symptomatic bradycardia, complex ventricular arrhythmia, wide QRS complex, left ventricular dysfunction, and also escape rhythm or heart rate below 50 or lung pauses, we need pacemaker as a class 1 indication. But even in asymptomatic adult patients with congenital complete AV block, pacemaker is a class 2A indication. Why? Um, this is an old study, relatively old study from 1995 from Denmark, which showed that many patients with asymptomatic AV block experience syncope, and even the first syncope has a high rate of mortality and morbidity. In addition, we have gradually declining ventricular rate in these patients and a high incidence of so-called acquired mitral insufficiency. And that's the reason that even in asymptomatic patients, the pacemaker implantation is a class 2A recommendation, considering that today, actually now we can use conduction system pacing instead of classic two-chamber pacemaker with RV lead on RV septum, so we can improve the prognosis in these patients. So in conclusion, this was the ECG from a young man, asymptomatic young man with congenital complete heart block and ventriculophasic arrhythmia. I hope you enjoyed this short video presentation, and I would like to invite you joining me here in my future video presentations. Once again, thank you for your attention.